The one thing that we always check initially is the occlusion set correct by the aligner company. Because if the occlusion is not set correctly, everything else is just doesn't matter. Because the teeth will move, but into a wrong position because the occlusion is off from the beginning. I don't know about you, but if half the orthodontists are afraid of controlling the root movements in extraction cases, as a GP, I would be terrified. I don't care if you just move from premolar to premolar or all the teeth. Orthodontics is orthodontics, so you will affect all the teeth during the treatment. The question is just how much. Imagine going to a football stadium. The orthodontist will be able to find the football stadium. If it's a reasonable orthodontist, he will be able to find the section you're going to sit in. And if he's really good, he will be able to find the row that you're going to sit in. But the exact spot where you're going to sit, he will never ever be able to find that with orthodontics.
Hello Protrusive, I'm Jazz Glanty and welcome back to your favorite dental podcast. I'm joined today by our guest, Dr. Jesper Hatt. All this dentist does is help other dentists with their treatment plans for aligners. From speaking to him, I gathered that he's no longer practicing clinically and is full-time clinical support for colleagues for their aligner cases. So there's a lot we can learn from someone who day in, day out has to do so much treatment planning and speaking to GDPs about their cases, how they're tracking, how they're not tracking, complications, and then years of seeing again, okay, how well did that first set of aligners actually perform? What is predictable and what isn't? And as well as asking what are the most common errors we make on our ClinChecks or treatment planning softwares, I really wanted to probe him further. I really wanted to ask him about clinical guidelines for occlusion after ortho. Sometimes we treat a case and whilst the aesthetics of that aligner case is beautiful, the occlusion is sometimes not as good. So let's talk about what that actually means. What is a not a good occlusion? What is a good occlusion? And just to offer some guidelines for practitioners to follow, because guess what? No orthodontist in the world is going to ever get the occlusion correct through ortho. Therefore, we as GPs are never going to get a perfect textbook occlusion. But we need to understand what is acceptable and what is a good guideline to follow. That's exactly what we'll present to you in this episode today. Now, this is a CE/CPD eligible episode, and as our main PDP episode, I'll give you a protrusive dental pearl. Today's pearl is very much relevant to the theme of orthodontics and occlusion we're discussing today, and it's probably a pearl I've given to you already in the past somewhere down the line, but it's so important and so key, I really want to just emphasize on it again. In fact, a colleague messaged me recently and it reminded me of this concept I'm about to explain. She sent me an image of a resin bonded bridge she did, which had failed. It was a lower incisor, and just a few days after bonding, it failed. And so this dentist was feeling a bit embarrassed and wanted my advice. Now, by the way, guys, if you message me for advice on Instagram, on Facebook, or something like that, it's very hit and miss. Like, my priorities in life are family, health, and everything that happens on Protrusive Guidance, our network. If you message me outside that network, I may not see it. The team might, but I may not see it. It's the only way that I can really maintain control and calm in my life. The reason for saying this, I don't want anyone to be offended. I'm not ignoring anyone. It's just the volume of messages I get year on year. They are astronomical, and I don't mind if you nudge me. If you messaged me something weeks or months ago and I haven't replied, I probably haven't seen it. Please do nudge me. And the best place to catch me on is Protrusive Guidance. If you DM me on Protrusive Guidance, the home of the nicest and geekiest dentists in the world, that's the only platform I will log in daily. That's our baby, our community. Anyway, so I caught this Facebook message and it was up to me to help this colleague. And one observation I made is that the lower teeth were all worn, the upper teeth were really worn, but this resin bond bridge Pontic, it just looked like a perfect tooth. The patient was something like 77 or 80, so it really made me think that, okay, why are we putting something that looks like a 25-year-old's tooth in a 77-year-old, but even forgetting age and stuff, you have to look at the adjacent teeth in the arch. Is your restoration harmonious with the other teeth in the arch? And of course, is the restoration harmonious with what's opposing it? Because it's just not compatible. So part one of this pearl is make sure any restoration you do, whether it's direct or indirect, is harmonious with the patient's arch and with the opposing teeth and with their occlusal scheme. Because otherwise, if you get rubber dam on and you give your 75-year-old patient beautiful composite resin, it's got all that cuspal fissure pattern and anatomy, and you take that rubber dam off and you notice that all the other teeth are flat and the opposing teeth have flat amalgams, guess what? You're going to be making your composite flat. Whether you like it or not, you created a restoration that's proud, right? That's why you did not conform to the patient's own arch or existing anatomical scheme. So the part B of this is the thing that I get very excited to talk about, right? So sometimes you have a worn dentition, but then you have one tooth that's not worn at all. It's like that in-standing lateral incisor, right? Think of an upper lateral incisor that's a bit in-standing. And you see some wear on all the incisors, but that lateral incisor does not have any wear in it because it was never in the firing line. It was never in function. It was never in parafunction. Now, if you give this patient aligners or fixed appliances, you're doing ortho, and you're now going to align this lateral incisor, so it's now going to eventually get into occlusion, and it will be in the functional and parafunctional pathways of this patient. Do you really think you can just leave that incisor be? No, it's not going to be compatible with the adjacent teeth. It's not going to be compatible with the opposing tooth and the occlusal scheme. So guess what? You have to get your burr out or your soft flex disc out, and you have to bake in some years into that tooth. Or you have to build up all the other teeth if appropriate for that patient. You just gotta think about it. And I hope that makes sense so you can stay out of trouble, you're not gonna get chipping, and you can consent your patient appropriately for enamel adjustment, which is something that we do talk about in this episode. I think you're in for an absolute cracker. Hope you enjoy. I'll catch you in the outro. Dr. Jesper Hatt, thank you so much for coming to the Protrusive podcast. We met in Scandinavia, in Copenhagen. You delivered this wonderful lecture, and it was so nice to connect with you then and to finally have you on the show. Tell us, how are you? Where in the world are you? And tell us about yourself.
Oh, thank you for the invitation, first of all. Well, I'm a dentist. I used to, practice in Denmark since I originally come from Denmark. My mother's from Germany, and now I live in Switzerland and have stopped practicing dentistry since 2018. Now I only do consulting work, and I help doctors around the world with making their aligner business successful.
And this is like probably clinical advice, but also like strategic advice and positioning and that kind of stuff. Probably the whole shebang, right?
Yeah, I mean, I have a team around me. So my wife's a dentist as well, and I would say she is the expert in Europe on clear aligners. She's been working for, first of all, in our practice. She's a dentist too. She worked with me in the practice. We practiced together for 10 years. Then she became a clinical advisor for Align Tech with responsibility for clinical support in all of Scandinavia. She was headhunted to ClearCorrect, worked in Basel, while I was doing more and more consulting stuff in Denmark. And so she was traveling back and forth, and I considered this to be a little bit challenging for our family. So I asked her, well, why don't we just relocate to Switzerland since ClearCorrect is located there? And sure we did. And after 2 years, she told me, I think, clinical support, it's okay. And I like to train the teams, but I'd really like to do more than that, because she found out that doctors, they were able to book a spot sometime in the future, let's say 2 weeks out in the future, at a time that suited the doctors. No, not the doctors, ClearCorrect or Invisalign or whatever clear aligner company you use. So as a doctor, you're able to, block the spot. And at that time, you can have your 30 minutes one-on-one online with a clinical expert. And she said it's always between the patients or administrative stuff. So they're not really focused on their ClearCorrect or clear aligner patient. And so they forget half of what I tell them. I can see it in the setups they do. They end up having to call me again. It doesn't work like that. I would like to help them.
It's a clunky pathway of mentorship.
Yes. And so she wanted to change the way clinical support was built up. So we do it differently. We do it only in writing so people can remember what we are telling them. They can always go back in the notes and see what's been going on, what was the advice we gave them. And we offer this co-creation support where we take over most of the treatment planning of the ClearCorrect or clear aligner or Spark or Invisalign or Angel aligner treatment planning. So we do all the digital planning for the doctor, deliver what we think would be the right for the patient based on the feedback we initially got from the doctor. And then the doctor can come back and say, well, I'd like a little more space for some crowns in the front, or I would like the canines to be in a better position in order to achieve immediate posterior disclusion. And so we can go into this discussion back and forth and adjust the digital setup in a way that is more realistic and predictable, and do it all for the doctor. So they, on an average, they, spend 4 to 6 hours less, or spent less than 4 to 6 hours less chair time hours when they use that kind of service compared to if they do everything themselves. And on top of that, you can put your planning time. She was responsible for that, and it works quite well. I still remember when we initially got on all these online calls, and we would see fireworks in the background and confetti coming down from the top and all of that.
Exactly. So excuse that little blip, but okay. So essentially, what you're doing is, as an Align user myself, for example, you're doing the clean checks. You're helping, supporting with the clean checks, the planning, and I've got a lot of questions about that. The first question I'll start with, which is off the script, but there's probably 100 different mistakes that could happen in a clean check, right? But what is the most like repeatable, predictable, common mistake that you will see when a new user sends a case to you to help them with their planning? What's the most common mistake that you will see in a setup?
Two things, actually. The one thing that we always check initially is the occlusion set correct by the aligner company? Because if the occlusion is not set correctly, everything else is just doesn't matter, because the teeth will move, but into a wrong position because the occlusion is off from the beginning. And so we always check that as the first part.
So let's talk about that, because that might be confusing for a younger colleague, because they're like, hey, hang on a minute, I scanned the bite left and right. What do you mean the occlusion is wrong? Because surely that gets carried through into what I see on the clean check. So what do you think is the mechanism for this to happen?
There are two different reasons. I'm from a time when I graduated in 2003, so that was before digital dentistry. So when I went to the Pankey Institute and learned everything about, functional occlusion and all of that stuff, I also found out that most of my patients, when I put silicone impression material between the teeth and asked the patients to bite together, they would always protrude a little bit, unless I instructed them to bite hard on the posterior teeth. And when we got the scanners, when we put a scanner into the cheek and pull the cheek, most patients, when we asked them to bite together to do the intraoral scan of the bite, they also protrude a little bit. Not much, but enough to set the bite wrong. So that is the one challenge when the technicians of the aligner companies put the models together. The other challenge is that some of the aligner companies, they let the technicians set the models. We always, as the first thing when we see a case, we always look at the photos, the clinical photos, and that's why the clinical photos have to be of great quality. So we look at the clinical photos of the patient.
And also in those clinical photos, Jesper, that you have to coach them correctly to bite. You have to notice if they're biting wrong, even in the photos, because then it just duplicates the error, right? And that's where good photography and actually being able to coach the patient is so imperative.
Yes, that's correct. But we compare the two, and usually if we see a difference, we ask the doctor, is what we see in the photo correct, or is what we see on the digital models correct? Because we don't like, differences. So that would be the first step to look for.
And what's the second?
The second thing is that when you look at the setup, the anterior teeth are usually, I'm trying to show you that the anterior teeth are very, very steep. Typically with aligners, it's a lot easier to tip the crowns. So when you have a class 2 patient, deviation 1, where the anteriors are in a forward position, proclined, and you have a lot of space between the anteriors of the maxilla and the mandible, then the easiest thing on a digital setup is to just, retrocline the anteriors of the upper to make them fit the lowers, which you could then procline a little bit. But usually you have very steep relationships between the two. And
so you're more likely to restrict the envelope of functional interference anteriorly. You kind of You are obviously reducing the overjet, but you may end up reducing you make like a wall contact rather than an elegant, a more open gate.
Yes, and there's another dimension to this, because when we work with orthodontics, one of the most important things to look for is actually the profile of the patient. Because let's say I'm trying to illustrate this now, so I hope you get a 90.
So you have to describe it for our audio listeners as well. So we're looking at a profile view of Jesper.
Yes, so I'm turning the side to the camera. I hope you can see my profile here. So let's say I had flared anterior maxillary teeth and I wanted to retrocline them. It would have an effect on my upper lip. So the lip would fall backwards if I just, retrocline everything. And every millimeter we move the anteriors in the maxilla in a posterior direction, we will have a potential lip drop of 3 millimeters. In addition, if we don't get the nasolabial angulation correct, we risk the lower face will simply disappear in the face of the patient. So soft tissue plays a role here. So we cannot just retrocline the teeth. It looks great on the computer screen, but when it comes to reality, we'll have a functional challenge, we'll have a soft tissue support challenge, and in addition, we'll have long-term retention challenges as well. Because when you have a steep inclination, the anterior teeth in the mandible they don't have any kind of support. They will not be stopped by anything in the maxillary, by the maxillary teeth, which you would if you had the right inclination between the teeth, which would be about 120 degrees. So why do aligner companies always set the teeth straight up and down in the anterior part? We wondered about this for years. We don't have a strict answer. We don't know exactly why it's like this, but I have a hunch. I think there are two things to it. First of all, the most easy thing to do with an aligner is to, move the crown, so we can just tip the teeth. You take them back. You make a lot of IPR, and then you just tip them so they retroclined. Secondly, all aligner companies, they come from the United States, and in the United States there is a higher representation of class 3 patients. Now, why is that important? All our patients can be put into two different categories in regards to how they move their mandible. They are the crocodiles that only open and close, like move up and down. And then we have the cows. Exactly. And then we have the cows that move the mandible around, or the camels. I mean, every camel, if you've seen a camel chew, it's just, moving from side to side.
Horses as well, they kind of do that. But I'm glad you didn't say rats, because I always, it's more elegant to be a crocodile than a rat.
Exactly. And I usually say we only tell the crocodiles. So...
Yeah.
So why is this a challenge? And why isn't it a challenge with class 3 patients? Well, all real class 3 patients act like crocodiles. So they don't move from side to side. So from a functional perspective, it's really not a problem having steep anterior inclination or steep relationships, as long as you have a stable stop where the anteriors will not, elongate and create the rat effect. So they just elongate until they hit the palate. If you can make a stop in the anterior part of the occlusion, then you'll have some kind of stability with the class 3 patients. But with class 2 patients, we see a lot more cows. So they move the mandible from side to side and anterior and back and forth, and they have the mandible going all kinds of places. And when they do that, we need some kind of anterior guidance to guide the mandible. I usually say the upper jaw creates the framework within which the mandible will move. So if the framework is too small, we fight the muscles. And whenever we fight the muscles, we lose, because muscles always win. It doesn't matter if it's teeth, if it's bone, if it's joints.
The joints.
They all lose if they fight the muscles.
As Peter Dawson would say, right? In the war between teeth and muscles, or any system and muscles, the muscles always win, absolutely. And the other analogy that you remind me of is the maxilla being like a garage or garage from the UK, like a garage, and the mandible being like the car. And if you're really constrained, you're going to crash in, and you're going to, everything will be in tatters. So that's another great way to think about it. So, okay, that's very, very helpful. Because there's so much I want to cover, right? And I think you've really summed it up nicely. But one thing, just to finish on this aspect of that common mistake being that the upper anteriors are retroclined, really what you're trying to say is we need to be looking at other modalities, other movements. So I'm thinking you're saying extraction if it's suitable for the face, or distalization. Are you thinking like that, rather than the easier thing for the aligners, which is to retrocline? Am I going about it the right way?
It depends on the patient.
Of course, of course.
Rule of thumb, if your GP don't ever touch extraction cases. Rule of thumb. Why? Because it is extremely challenging to move teeth parallel. So you will especially with aligners. I mean, I talked with a very respected orthodontist once, and I asked him, well, what do you think about GPs treating extraction cases where they extract, 2 premolars in the maxilla? And he said, well, I don't know how to answer this, but let me just explain to you. Half of my orthodontist colleagues, they are afraid of extraction cases. And I asked him, why? Because it's so hard to control the root movements. Now, I don't know about
with aligners. We're specifically talking about aligners here, right?
With all kinds of orthodontic appliances.
Thank you.
So now, I don't know about you, but if half the orthodontists are afraid of controlling the root movements in extraction cases, as a GP, I would be terrified. And I am a GP. So I usually say, sometimes you will have so much crowding and so little space in the mandible. So there's an incisor that is almost popped out by itself. In those cases, yes, then you can do an extraction case. But when we're talking about premolars that are going to be extracted, or if you want to close a space in the posterior part by translating a tooth into that open space, just don't. It's just the easiest way to end up in a disaster, because the only thing you will see is just teeth that tip into that space, and you will have a really hard time to control the root movements, getting them corrected again.
Well, thank you for offering that guideline. I think that's very sage advice for those GPs doing aligners, to stay in your lane and just be, the best thing about being a GP, Jesper, is you get to cherry pick. Right? There's so many bad things about being a GP. Like, you literally have to be kind of like a micro specialist in everything, in a way, right? And so sometimes it's good to be like, you know what, I'll keep this and I'll send this out, and being selective, and case selection is the crux of everything. So I'm really glad you mentioned that. I mean, we touched already on so much occlusion. The next question I'm going to ask you then is, like you said, a common error is the bite and how the bite appears on the ClinCheck or whichever software a dentist is using. Now, related to bite, vast majority of orthodontic cases are treated in the patient's existing habitual occlusion, their maximum intercuspal position. Early on in my aligner journey, I had a patient who had an anterior crossbite, and that because that anterior crossbite, their jaw deviated. It was displaced, the lower jaw displaced. And then I learned from that actually, for that instance, perhaps I should not have used an MIP scan. I should have used a more like centric relation or first point of contact scan before the displacement of the jaw happens. So that was like always in my mind. Okay, sometimes we can and should be using an alternative TMJ position or a bite reference other than MIP. Firstly, what do you think about that kind of scenario? And are there any other scenarios which you would suggest that we should be not using the patient's habitual occlusion for their bite scan for planning orthodontics?
Well, I mentioned that I was trained at the Bank Institute, and when you start out right after, I've spent 400 hours over there. Initially, I thought I was a little bit brainwashed by that, because I thought every single patient should be in centric relation. Now, after having put more than 600 patients on the bite appliance first, before I did anything, I started to see some patterns. And so today I would say it's not all patients that I would get into centric relation before I start treating the teeth. But when we talk about aligner therapy and orthodontic treatment, I think it's beneficial if you can see the signs for those patients where you would say, something in the occlusion here could be a little bit risky. So let's say there are wear facets on the molars that will always, trigger a red flag in my head. Let's say there are cross bites or bite positions that kind of log in the teeth. We talked about class 3 patients before, and I said if it's a real class 3 patients, it's a crocodile. But sometimes patients are not real class, skeletal deviation class 3 patients. They are simply just being forced into a class 3 due to the occlusion. That's where the teeth fit together. So once you put aligners between the teeth and plastic covers the surfaces, suddenly the patients are able to, move the jaws more freely, and then they start to seat into centric. That may be okay. Usually it is okay. The challenge is the consequences. So when you're a GP and you suddenly see a patient move into centric relation, and you find out, whoa, there's, on a horizontal level, there's a 4 to 6 millimeter difference between the initial starting point and where we are now. And maybe we create an 8 millimeter open bite in the anterior as well, because they simply seat that much. We have seen it. So is this a disaster? Well, it depends. If you have informed the patient well enough initially and said, well, you might have a lower jaw that moves into a different position when we start out. And if this new position is really, really off compared to where you are right now, you might end up needing maxillofacial surgery. Then the patient's prepared. But if they're not prepared and you suddenly have to tell them, I think we might need maxillofacial surgery, I can come up with a lot of patients in my head that would say, hey, doctor, that was not part of my plan. And will be really disappointed. And at that point, there's no turning back. So you can't, reverse. So I think if you're unsure, then you're sure. Then you should use, some kind of deprogramming device or figure out where is centric relation on this patient. If there isn't that much of a difference between maximum intercuspation and centric relation, I don't care, because once you start moving the teeth, I don't care if you just move from premolar to premolar or all the teeth. Orthodontics is orthodontics. So you will affect all the teeth during the treatment. The question is just how much? And sometimes it's just, by putting plastic between the teeth that you will see a change, not in the tooth position, but in the mandibular position. And I just think it's nicer to know a little bit where this is going before you start. And the more you see of this, I mean, as I mentioned, after 600 bite appliance in the mouth of my patients, I started to see patterns. And sometimes in the end of, after 20 years of practicing, I started to say, let's just start, see where this ends. But I would always, inform the patients if it goes, totally out of control, we might end up needing surgery. And there's no way to avoid it if that happens. And if the patients were okay with that, okay, we'll just start out. Because, I mean, is it bad? No, I just started the orthodontic treatment and I set the teeth as they should be in the right framework. Sometimes, the upper and the lower jaw don't fit together. Well, send them to the surgeon and they will move either the upper or the lower jaw into the right position and then we have it. No harm is done because we have just done the initial work that the orthodontist would do. But I will say, when I had these surgical patients, let's say we just started out with aligners and we figured, I can't control this enough, I need a surgeon to look at this. Then I would send them off to an orthodontist and the orthodontist and the surgeon would take over. Because it's, surgical patients and kids, that's the second, group of patients besides the extraction cases that I would not treat as a GP because we simply don't know enough about how to affect growth on kids. And when it comes to surgery, there's so much that is, so much knowledge that we need to know and a collaboration with the surgeons that we're not trained to handle. So I think that should be handled by the orthodontist as well.
I think collaborative cases like that are definitely specialists in nature. And I think that's a really good point I think the point there was informed consent. The mistake is you don't warn the patient or you do not do the correct screening, right? So again, I always encourage my guests, so Jesper, you included that, we may disagree and that's okay. Let's see that as a beauty of dentistry, right? So something that I look for is if the patient has a stable and repeatable maximum intercostal position, things lock very well, and there's a minimal slide. Like I use my leaf gauge and the CRCP is like, a small number of leaves and the jaw hardly moves a little bit, then, there's no point of now uncoupling them, removing that nice posterior coupling that they have, just to chase this elusive joint position, then they have to do so many more teeth. So, but when we have a breakdown in the system, which you kind of said, if there's the wear as one aspect, or we think that, okay, this patient's occlusion is not really working for them, then we have an opportunity to do full mouth rehabilitation in enamel. Right, because that's what orthodontics is. And so that's a point to consider. So I would encourage our GP colleagues to look at the case, look at the patient in front of you and decide, is this a stable, repeatable occlusion that you would like to use as a baseline? Or if there's something wrong, then consider referring out or considering, if you're more advanced in occlusion studies, to use an alternative position, not the patient's own bite as a reference. So anything you want to add to that or disagree with in that monologue I just said there?
No, I think there's one thing I'd like to... I'd like the listeners to consider this. I see a lot of fighting between orthodontists and GPs, and I think it should be a collaboration instead. There's a lot of orthodontists that are afraid of, GPs taking over more and more aligner treatments, and they see a huge increase in the amount of cases that go wrong. Well, there's a huge increase of patients being treated, so there will be more patients just statistically that will, get into problems. Now, if the orthodontist is smart, in my opinion, that's my opinion, they reach out to all their referring doctors and they tell them, look, come in, I will teach you which cases you can start with and which you should refer. Let's start there. Start your aligner treatments. Start out, try stuff. I will be there to help you if you run into problems. So whenever you see a challenge, whenever there's a problem, send the patient over to me and I'll take over. But I will be there to help you if anything goes wrong. Now, the reason this is really, really a great business advice for the orthodontists is because one should teach the GPs around you to look for deviations from the normal, which would be the indication for orthodontics. The doctors start to diagnose and see a lot more patients needing orthodontics and, prescribe it to the patients or at least propose it to the patients, which would initially not do much more than just increase the amount of aligner treatments. But over time, I tell you, all the orthodontists doing this, they are drowning in work. So they will literally be overflown by patients being referred by all the doctors because suddenly all the other doctors around them start to diagnose orthodontically. They see the patients, which they haven't seen before. So I think this is, from a business perspective, it's a really, really great thing for the orthodontists to have a collaboration with this. And it will also help the GPs to feel more secure when they start treating their patients. And in the end, that will lead to more patients getting the right treatment they deserve. And I think that is the core. That is what's so important for us to remember, that that's what we're here for. I mean, yes, it's nice to make money. We have to live. It's nice with a great business. But what all dentists I know of are really striving for is to treat their patients to the best of their ability. And this helps them to do that.
Ultimate benefactor of this collaborative approach is the patient. And I love that you said that. I think I want all orthodontists to listen to that soundbite and take it on board and be willing to help. But most I know are really lovely orthodontists, and they're helping to teach their GPs and help them. And in return, they get lots of referrals. And I think that's the best way to go. Let's talk a little bit about occlusal goals we look for at the end of orthodontics, right? This is an interesting topic. I'm going to just start by saying that just 2 days ago, I got a DM from one of the Protrusive. His name is Keith Curry. Shout out to him on Instagram. And he just sent me a little message. Jazz, and do you sometimes find that when you're doing alignment as a GP, that it's conflicting the orthodontic, the occlusal goal you're trying to get? And I knew it was getting to is that scenario whereby you have the kind of class 2 division 2. Right? But they have anterior guidance. Now you align everything, okay? And now you completely lost anterior guidance. And so the way I told him is that, you know what? Yes, this is happening all the time. Are we potentially at war between an aesthetic smile and a functional occlusion? And sometimes there's a compromise. Sometimes you can have both, but that to achieve both needs either a specialist set of eyes or lots of auxiliary techniques or a lot more time than what GPs usually give for their cases. So first, let's touch on that. Do you also agree that sometimes there is a war between what will be aesthetic and what will be a nice functional occlusion? And then we actually talk about, okay, what are some of the guidelines that we look for at the end of completing an aligner case? Hello, YouTube Protrusive. I know you're watching on YouTube, and I hope you're enjoying this episode so far. But I wanted to highlight, in case you don't know yet, we have an amazing viewing experience on protrusive.app, our website, our network, our platform. So I just want to spend a minute to show you what this looks like. On the left side, you see the navigation, and when you join the app, you get a 1-minute video tour of the entire network. Now, in terms of where the magic happens, that's in the Protrusive community, because you might come for the content, but you'll stay for the community of the nicest and geekiest dentists in the world. We have all these polls, we have a chat group, there's always active chats and dentists helping dentists. And really what I want to do is create a really supportive environment that's not like the environment we have on Facebook, and it's built on the values of niceness and geekiness. If you are nice and geeky, you belong here. Now, to make this a safe space, we have a manual process of approval. We actually verify that you are a dental professional before you get in here. So we have hundreds of applicants a day. So if it's been about 2 days and you haven't heard anything, either something's in your junk or you need to reach out. If you're still waiting to join your tribe, email marie@protrusive.co.uk. That's MARI@protrusive.co.uk, and she'll investigate what's happened. Now, all the videos you have on YouTube are also on here, but you actually have some extra ones for free that you don't have on YouTube. So you get some bonus content that's not on YouTube. And actually for the future, I'm not taking things out of YouTube, but some things are not appropriate for the wider public, and I want to sort of safeguard that information, which is like dentist talk, if you like. So that's why a lot of the content is only here and not on YouTube. So you're kind of missing out if you're not on here. That's why I'd love for you to join there. And if you join one of our paid plans, then what you get is access to the CE quiz, like this one, and you can get CPD or CE certificates, and also you get our premium notes. So these are a great aid memoir or revision for an episode to really cement your learning. And whilst we have ads and YouTube places ads on YouTube, we don't have that on our network. So for the paid plan, you get to see all of the premium notes without any of the ads. And of course, you get to support Team Protrusive and help us to continue what we're doing. I'm just going to gloss over the Protrusive Vault, which has all our infographics and downloadables. These are all our masterclasses at this moment in time, and we're always planning to add more. And if you look at them, there's about 1, 2, 3, it's about 7 of them. But actually, if you look at the replay section, some of the live masterclasses that I've done and some of the training that people pay for on other websites is all on there, included as part of the masterclass subscription. And if you're a student, don't fear, we have a special section for you with all the student student notes, which anyone can access. So for example, here is one on exodontia. So it's all there waiting for you on Protrusive guidance. Please head over to the website, which is protrusive.app. Make an account on your browser. This could be Safari, Chrome, however you want to do it. And once you've made your login, then you can download the iOS or Android app and then log in through there. So the reason to make the subscription primarily on the website first is that you get access to a free trial, which you don't get if you do make an account on Android, iOS. If you make it on the website, you get access to the free trial and you get our best price if you sign up through protrusive.app. So our best deals and free trials are only on protrusive.app. Of course, we always put the link below in the description. And thank you so much for enjoying our videos on YouTube. But it's now finally time to level up your experience. Back to the episode.
Great question and great observation. I would say I don't think there's a conflict because what I've learned is form follows function. So if you get the function right, aesthetics will always be great. Almost always. I mean, we have those crazy shaped faces sometimes. But so form follows function. The challenge here is that in adult patients, we cannot manipulate growth. So a skeletal deviation is a skeletal deviation, which means if we have a class 2 patient, it's most likely that that patient is a skeletal deviation. I rarely see a dental deviation. It happens, but it's really, really rare. So that means that in principle, all our class 2 and class 3 patients are surgical patients. However, does that mean that we should treat all our class 2 and class 3 patients surgically? No, I don't think so. But we have to consider that they are all compromise cases. So we need to figure a compromise. So initially, when I started out with my occlusal knowledge, I have to admit, I didn't do the orthodontic treatment planning. I did it with Helle, and she would give me feedback and tell me, I think this is doable and this is probably a little bit challenging. If we do this instead, we can, we can keep the teeth within the bony frame. We can keep them in a good occlusion. Then I would say, well, you have a flat curve of spee. I'd like to have a little bit of curve. It's called a curve of spee and not the orthodontic flat curve of spee. And then we would have a discussion back and forth about that. Then initially, I would always want, anterior coupling, where the anterior teeth would touch each other. I have actually changed that concept in my mind and, accepted the orthodontic way of thinking, because most orthodontists will leave a little space in the anterior. So when you end the orthodontic treatment, you almost often have a little bit of space between the anterior teeth so they don't touch each other. Why? Because no matter what, no matter how you retain the patient after treatment, there will still be some sort of relapse. And we don't know where it will come or how, but it will come. Because the teeth will always be positioned in a balance between the push from the tongue and from the cheeks and the muscles surrounding the teeth. So, and that's a dynamic that changes over the years. So I don't see retention as a 1 or 2 year thing. It's a lifelong thing, and the surrounding tissues will change the pressure and thereby the balance between the tongue and the cheeks, and where the teeth would naturally settle into position. Now, that said, as I mentioned initially, if we fight the muscles, we lose. So let's say we have an anterior open bite, that will always create a tongue habit where the patient positions the tongue in the anterior teeth when they swallow. Because if they don't, well, food and drink will just, be splashed out between the teeth. They can't swallow. It will just be pushed out of the mouth. So
isn't that not like a secondary thing? Like that tongue habit is secondary to the AOB. So in those cases, if you correct the anterior open bite, theoretically, should that tongue posture not self-correct?
Well, we would like to think so, but it's not always the case. And there's several reasons to it. Because why are the teeth in the position? Is it because of the tongue or because of the tooth position? Now, spacing cases is one of those cases where you can really illustrate it really well. It looks really easy to treat these patients. If we take away all the soft tissue considerations and the profile photo, you can just retract the teeth and you close all the spaces. Super easy, tipping movements. It's super easy orthodontically
Very
to move
quick
the teeth.
as well.
Yes. However, you restrict the tongue. And now we have a retention problem. So there are 3 things that can happen. You can bond a retainer on the lingual side or the palatal side of the teeth, upper, lower, just bond everything together. And after 3 months, you will have a diastema distal to the bonded retainer because the tongue simply pushes all the teeth in an anterior direction.
I've also seen, Jesper, I don't know if you've probably seen this as well, the patient's tongue being so strong in these exact scenarios where the multiple spacing has been closed, which probably should have been a restorative plan rather than an orthodontic plan, and the retainer wire snaps in half
Yes,
from the
that's
tongue.
all.
That always fascinated me.
Yeah, well, you will see debonding all the time, even though you sandblast and you follow all the bonding code. And debonding, breaking wires, diastemas in places where you think, how is that even possible? Or, and this is the worst part, or you induce sleep apnea on these patients because you simply restrict the space for the tongue. So they start snoring and then they have a total different set of health issues afterwards. So spacing, I mean, this just illustrates the power of the tongue and why we should always be careful with spacing cases. I mean, spacing cases, in my opinion, are always to be considered ortho-restorative cases. Now you can consider, do you want to leave some space distal to the canines because there you can create an optical illusion with composites? Or do you want to distribute space equally between the teeth and place veneers or crowns or whatever? And this is one of those cases where we'd say aligners are just fabulous compared to fixed appliances. Because if you go to an orthodontist only using fixed appliances and you tell that orthodontist, please redistribute space in the anterior part of the maxilla, and I want exactly 1.2 millimeters between every single tooth in the anterior segment. 6 years later, he's still not reached that goal because it just moves back and forth. Put aligners on, 3 months later, you have exactly, and I mean exactly, 1.2 millimeters of space between each and every single tooth. When it comes to intrusion and extrusion, I would probably consider using fixed appliances rather than aligners if it's more than 3 millimeters. So every, orthodontic system, and aligners are just an orthodontic system. Each system has its pros and cons, and we just have to consider which system is the right for this patient that I have in my chair. But back to the tongue issue, what should we do? I mean, yes, there are two different schools. So if you have, let's say, a tongue habit that needs to be treated, there are those that say we need to get rid of the tongue habit before we start to correct the teeth. And then there are those that say that doesn't really work because there's no room for the tongue. So we need to create room for the tongue first and then train the patient to stop, the habit. Both schools and both philosophies are being followed out there. I have my preferred philosophy, but I will let the listener, start to think about what do they believe and follow their philosophy, because there is nothing here that is right or wrong. And
I think the right answer, Jesper, is probably speak to that local orthodontist who's going to be helping you out, and whatever they recommend, their religion, follow that one, because then at least you have something to defend yourself. Like, okay, I followed the way you said, let's fix it together now.
That's a great one. Yeah, exactly.
Okay, well, just touching up on the occlusion then, sometimes we do get left with suboptimal occlusions, but to be able to define a suboptimal occlusion, let's wrap this occlusion element up. And when we are completing an orthodontic case, let's talk aligners specifically, when the aligners come off and the fixed retainers come on, for example, and the patient's now in retention, what are some of the occlusal checkpoints or guidelines that you advise checking for to make sure that, okay, now we have a reasonably okay occlusion and let things settle from here? For example, it would be, for me, a failure if the patient finishes the aligners and they're only holding articulating paper on one side and not the other side. Right, that's for me is a failure. Or if they got an posterior open bite bilaterally, okay, and then there's okay, we need to go refinement, we need to get things sorted. But then where do you draw the line? How extreme do you need to be? Do you need every single tooth in shim stock foil contact? Because then we're getting really, beyond the, that we have to give the adaptation some wiggle room to happen. So I would love to know, from your learning at Pankey, from your experience, what would you recommend is a good way for a GP to follow about, okay, it may not be perfect and you'll probably never get perfect, okay? And one of the orthodontists that taught me, he said he's never ever done a case that's finished with a perfect occlusion, ever. No. And he said that to me, right? So that...
And that's exactly the point with orthodontics. I learned that, imagine going to a football stadium. The orthodontist will be able to find the football stadium. If it's a reasonable orthodontist, he will be able to find the section you're going to sit in. And if he's really, really, really good, he will be able to find the row that you're going to sit in. But the exact spot where you're going to sit, he will never, ever be able to find that with orthodontics. Mm-hmm. And this is where settling comes in and a little bit of enamel adjustments.
I'm so glad you said that. I'm so glad you mentioned enamel adjustment. It's a very dirty word, but I agree with that. And here's what I teach on my occlusion courses is like, I say, like, what we do with aligners essentially is we're tampering with the lock. Let's say the upper jaw is the lock, okay? It's the stagnant, it's the still one. We're tampering with the key, okay, which is the lower jaw, okay, the one that moves. We tamper with the key and the lock, and we expect them both to fit together at the end without having to shave the key and to modify the lock. So for years, I was doing aligners without enamel adjustment because my eyes were not open. My mind was not open to this, okay? And as I learned, and now I use digital measuring of occlusion stuff, and I seldom can finish a case to get a decent, for my criteria, which is higher than it used to be, and my own is part of my own growth that's happened over time, is that I just think it's an important skill that GPs are not taught, and they should be, to finishing. It's all about finishing that case, right? And I think I agree with you that some adjustment goes a long way. We're not massacring enamel. It's little tweaks to get the...
Exactly. And I like the sound there because sometimes you hear that, it doesn't really sound right, but that's better.
That's the one. You know, it reminds me of that lecture you did, right, in Copenhagen. You did this cool thing, which I've never seen anyone do before. You sat with like one leg over the other, right? Yep. And you said, okay, guys, bite together, everyone bit together. And then you swapped the legs. And so the other leg was over the other and bite together. And then you said, okay, whose occlusion felt different? And about a third of the audience put their hand up, I think. Tell us about that for a second.
Well, just promise me we go back to the final part, because there are some things we should consider.
Let's save this as a secret thing at the end for incentive for everyone to listen to the podcast, how the leg position changes your occlusion. Let's talk about the more important thing. I digressed, okay? Let's talk about the occlusal goals.
Because I think it's important. I mean, if you do enamel adjustments in the end, so when we finish the treatment, when we come to the last aligner in the treatment plan, I think we should start by breaking things down to the simplest way possible. Start by asking the patient, are you satisfied with the way the teeth look? Yes or no. If she's satisfied, great. How do you feel about the occlusion? Well, it fits okay. Great. Now the patient is happy. There's nothing she wants to or he wants to change. Then you look at the occlusion. Now, it is important to remember that what we see on the computer screen on the aligner planning tools will never, ever correspond 100% what we see to what we see in the mouth of the patient. And there are several reasons for that. But one of the things that we have found to be really interesting is that if you take that last step and you say, okay, occlusion doesn't fit exactly as on the screen, but it's kind of there. If you use that last step and you don't do a rescan for a retainer, but you use the last step of the aligner treatment as, the reference for your aligner retainer, we sometimes see that over 6 months, if the patient wears that aligner 22 hours a day for another 3 to 6 months, the teeth will settle more and more into the aligner and create an occlusion that looks more and more like what you see on the screen, which to me just tells me that the biology doesn't necessarily follow the plan everywhere in the tempo that we set throughout the aligner plan, but over time, at the last step, if it's just minor adjustments, the teeth will actually move into that position if we use the last stage as a reference for the retainer. Now, if we do a scan at that point and use that as, a reference for creating an aligner retainer, then we just keep the teeth in that position. Now, if the teeth are a little bit more off...
I'm just going to recap that, Jesper, because I understood what you said there, but I want to just make sure I fully understood it. When we request, for example, a line, Vivera retainer, right? It gives you an option that I will submit a new scan or use the last step. And actually, I seldom use that, but now I realize you're right. It makes sense that what you said there. But then on the one hand, if the aesthetic's good and the patient's occlusions feels good, what is your own then judgment to decide whether we're still going to allow for some more settling and occlusal changes to happen over over a year using the Vivera retainers based on the ClinCheck last aligner profile, rather than, okay, let's just retain to this position. What is making you do the extra work, extra monitoring?
To me, it's not extra monitoring. It's just basic. I mean, it's just part of my protocol. I follow the patients. And it's, honestly, to me, it's just time saving to just use the last step in the aligner. Because, I mean, if the plan is right, and if the teeth have been tracking, well, they should be in that position. Why do I then need to, rescan for Vivera retainers or for other kinds of retainers? Now, if the occlusion is a little bit more off, and in a minute you'll probably ask me when do I see which is which, and I can't really tell you about experience, but that's the beauty of this. So if I see there's a little bit more deviation and I like some teeth, the occlusion isn't really good in one side compared to the other side, I would rather, have a bonded retainer from first premolar to first premolar in the mandible, combined with a Hawley or Beck or something like that retainer for the upper. You can order them with an acrylic plate, covering some of the anterior teeth so they keep that position. But that allows the teeth to settle. And over a 3 month, you should see some kind of improvement. If you don't see enough improvement, and let's say you still have a tendency for a kind of an open bite in one side, you can always add some cross elastics. Put some buttons on the upper, on the lower, instruct the patient to use these, and then in 3 months, you will have the occlusion you want to. Now, once that is being established, you have that kind of occlusion, you need to keep the teeth there for at least 6 months before you do some kind of equilibration or enamel adjustment. Because if you do the enamel adjustment right after you have reached your final destination for the teeth will still settle and move.
Mm-hmm.
So you do the equilibration, 2 weeks later, everything looks off again. You do the equilibration, 2 weeks later, things have changed again. So I prefer to wait 6 months before I do the final equilibration.
Mm-hmm.
Now, in this equation that we've been talking about here, it goes from very simple to more and more complex. And then we have to consider, well, did I expand the mandible posterior segment? If so, I can't just use, a bonded retainer on the lower. Then I need to add something to keep the teeth out there in combination with whatever I want in the upper. Do I want to keep, the Beck retainer or the Hawley, or do I want to change to something differently? So these kind of considerations have to, be there from the beginning of the treatment because, it costs additional money to order a Beck retainer compared to just an aligner.
A Beck retainer is the same as Hawley?
Well, no, it has a little different design. So
Okay. Oh, a Begg as in B-E-G-G.
Yes.
Yeah, got it. Okay.
And then in Denmark, we use the Jensen retainer, which is a Danish invention, which goes from, canine to canine or from first premolar to first premolar, but with a different type of wire, which keeps the teeth more in place compared to a round wire. So there are different variations. The most important part here is it allows the posterior teeth to settle so they can move, which they can't in an aligner to the same degree at least. Now, this is all really nice in teeth that only need to be moved into the right position. But most of our patients are adult patients, or they should at least be adult patients. Most of my patients were more than 30 years old. So if you have a patient with anterior crowding and you move the teeth into the right position where the teeth should be, the teeth are in the right position, but they still look ugly because they have been worn anteriorly by the position they were in when they were crooked. So when we position them, we still need to do some restorative work. Then what? We still need to retain those teeth. The patient wants to be finished now as fast as possible, so we can't wait the 6 months to, make the final touches. So we have to figure out what do we do. And then we have to think of some kind of retention strategy to keep the teeth in place during that restorative procedure. And at the end of an aligner treatment or any orthodontic treatment, 2 days is enough to have relapse in some patients. Some patients, it's not a problem. The teeth are just there to stay in the same position for 3 months, and then they start to move a little bit around. But other patients, you just have to look away and then go back to the teeth, and then they're in a different position. And you can't know what kind of patient do I have in my chair right now. So you have to consider the way you plan your restorative procedure in regards to how you retain the teeth during that phase. So if you want to do, anterior composites or veneers, do it all at once. Put in a bonded retainer, scan, and get, your aligner retainer as fast as possible, or use, a Beck or a Hawley or something like that that's a little bit more flexible. If you want to do crowns, then we have a whole different challenge. And then we have to consider how do we then retain the teeth.
Okay, well, I think that that was lovely. I think that gives us some thoughts and ideas of planning sequence of retention, which is the ultimate thing to consider when it comes to occlusion. Okay, yeah, you get the occlusion, but how do you retain it? But in many cases, as the patient's wearing aligners, the occlusion has been bedding in and it's fine, and you take off the aligners, the patient's happy with how it looks, they bite together, it feels good, you are happy that, yes, both sides of the mouth are biting together. Now, it might not be that every single contact is shim hold, but you got, let's say within 20 microns, 40 microns, okay, then some bedding happens. In that kind of scenario, would you be happy to say, okay, I'm going to scan your teeth as they are, because I'm happy with the occlusion, the occlusal goals are good and they're near enough to clean check, and go for the retainers to that position? Or is your default preference as a clinician to go for the Vivera or equivalent based on the last aligner on the clean check projection?
I would still go for the last aligner because I think the planning I've done is probably a little bit more precise than what I see clinically. However, I still expect that I will have to do a little bit of enamel reshaping at the end after 6 months. But that's okay. I mean, then their teeth, the changes are so small, so you can still use the last aligner or the Vivera retainer that you already have ordered. So it's not that much of a problem.
Which goes back to your previous point that if it's a big deviation, then you got to look at the alternative ways, whether you're going to go for refinement or you're going to allow some occlusal settling with a Hawley and a lower fixed retainer combination, or the elastics, like you said. Okay, just so we're coming to the end of the podcast. I've really enjoyed our time, but I would like to delve deep into just a final thing, which is a little checklist, helpful checklist for case assessment that you have for GDPs.
Yeah, thank you. First of all, one of the big challenges in a GP practice is being able to take a full series of photos, clinical photos, in 2 minutes without assistance. I think most dentists struggle with that, but that is a foundational prerequisite to any aligner treatment. Once you had the photos, I would sit down with the photos and I would consider the 6 different steps. 1, is this a patient that I could treat restoratively only? Because that would be the simplest for me to do. Next, moving up in complexity would be, do I need periodontal crown lengthening? Or next step would be, do I need to change the vertical dimension, or is there something about centrifugation that I should consider? Moving up a little bit on the complexity, are there missing teeth? Do I need to replace teeth with implants? Next step would be orthodontics. So this is step 5. The next last and the next most complex case we can treat is actually an aligner case, or orthodontics in general. And the last part would be, are the teeth actually in the right position in the face of the patient, or do I need surgery to correct the jaw position? So these 6 steps, I think they're helpful to follow, to just think, how can I break this, case down into more easy, digestible bits and pieces to figure out what kind of patient do I have in front of me. Now, if it's an orthodontic, if you consider it to be an orthodontic case or ortho-restorative case, here comes the challenge, case selection. How do you figure out, is this an easy, moderate, complex, or referral case? And here's the trick. Do 500 to 1,000 treatment plans or treatments with clear aligners, and then you know. But until then, you really don't. And this is where you should rely on someone you can trust who can help you do the initial case selection, because you can have 2 identical patients. One is easy and one is super complex, but they look the same. And so it's really nice if you have done less than 500 cases to have someone who can help you with the case selection. And I don't say this to sell anything, because we don't charge for that, because it's so essential that we don't do something that is wrong or gives us a lot of challenges and headaches in the practice. I mean, the practice runs really fast and lean oriented. So we need to make things digestible, easy to work with. And I think that's really important. And we've been talking
full circle. It goes full circle to what we said before about having that referral network, staying in your lane, knowing when to refer out, cherry picking. It all goes back full circle with that. And even, not even orthodontics, but restorative dentistry, case selection is just imperative in everything we do.
Yes. And there is, we always get the question when we do courses and we do consulting, can't you just show me a couple of cases that are easy to start with? And it works with implants, kind of. But with orthodontics, where we affect all the teeth, it's just not possible. I know the aligner companies want to show you some where you say, you can only just do these kind of cases and they are really easy. The fact is they're not. So, but they want to sell their aligners. I get it.
They are. Until it's not. It's like that famous thing, right? Everyone's got a plan until they get punched in the face, right? So it can seemingly can be good, but then a complication happens, and it's really about understanding what complications to expect, screening for them, and how you handle that. But thanks so much. Tell us. Go on. Sorry.
There are 3 things I'd like to end on here. So first of all, we've been talking together for about an hour about a topic that, if you want to take postgraduate education, it takes 3 years to become an orthodontist. And there is a reason it takes 3 to 4 years. However, I want to encourage the listener to think about this. Mercedes has never, ever excused last year's model. meaning that they always strive for a perfection. So if we go into the practice and we do the very best we can every single day, there is no way we can go back and excuse what we did, because we did everything to the best of our ability. And I think we all look at some of the work we did when we were in dental school and think, Jesus, did I do that? And so that is one thing that I took with me from the United States. Mercedes has never excused for last year's model. Secondly, when you're really frustrated and you think this is so overwhelming and why did I ever, get caught up with aligners, and I think it's just crappy because there's so much to learn. Look, there is a reason it's called a dental practice. We practice, practice, practice. So over time, you grow, you become more knowledgeable. And the most, annoying part of this is once you reach the age where you want to retire, there's so much knowledge you have picked up that you can't just, magically give on to the next generation. I think that's probably the most frustrating part. But practice, keep on making mistakes, and just tell your patient, be honest and say, thank you for just learning me how not to do this. Let me do it the right way. And what's that going to cost? See, that's the great part of it. This was a course that I'm paying for, so it will not cost you anything except a little bit of time. And then send them some flowers or something like that.
Good, lovely, because complications will happen. It's not if, but when. And that's a very elegant way to manage. I've said elegant 3 times, more times I've ever said it in a podcast. I said it more today. That's something about you.
Should we reveal? You were teasing for the connection between the feet and the teeth.
So why is it that when for a certain acceptable individual, when they change the way they sit, it changes their bite?
I believe that all muscles in humans are interconnected somehow. So sometimes the foot position or the muscles in the legs affect the muscles surrounding us, our face and neck, which affects the teeth and how they work together. And a lot of doctors question this and say, it can't be. There's no connection between the teeth and the legs. So to all the listeners out there, if you doubt me, sit on a chair, relaxed, both feet on the ground. Try to bite together. Register the very first point of contact. So the very first contact you register in your bite, where is it? Hold on to that. Cross one leg over the other, bite together again. Is there a difference between the initial bite that you had with both feet on the ground and one leg crossed over the other? And if you want to try it, just go from one leg and then switch to the other leg and cross that over. Most listeners will feel some kind of difference. There will be some that don't. But the beauty of this is it illustrates to us how everything in the body is interconnected. Sometimes problems arise from the legs or the hips or the back and affect the teeth. And then we have to refer the patients to someone who can treat that part. Sometimes the problems start with the teeth, and the teeth and the occlusion gives patients neck problems, back problems, hip problems, and foot problems. But we really don't know until we start to diagnose which is which we can do with deprogrammers and, bite appliances.
I want to add to this by saying something that one of my mentors, Bobby Supple, taught me, is that you're familiar with the T-scan, right?
Yes.
So it measures the timing, the force mapping, and so much. And then they made a similar version for the feet. So imagine you're standing on essentially the T-scan of the feet. So essentially you're seeing the heat map. Okay, when someone plants their foot, what pit hits first, how much pressure, what percentage of the force is going on this toe versus that toe and that part of the foot, right? And the fascinating thing was everyone's standing and obviously the color map is completely static. And then when you clench together, it changes. All you did was clench together, okay, right? And then the heat map of the foot, you did not move your foot at all, but the colors shift. How fascinating, right? So thanks for sharing that. And I think hoping everyone's gonna be like, oh, wow, that's pretty cool as they experiment on each other. But Jesper, tell us about you. I want to learn about, okay, if anyone's been inspired by today and want to learn more from you, how can they find your website? How can they learn about your services of consulting that you offer?
They can go to alignerservice.com. I think, can I share a link with you?
Yeah, I'll put it in the show notes. Yeah, absolutely. Yeah.
Oh, perfect. Because I will give you a link to a landing page where they can get access to. We have, first of all, a patient assessment note that is quite useful. There's a link to a free online course that helps the dentist and their assistants to take a full series of photos in 2 minutes without assistance. There's access to our own protocol when we treatment plan the patients. We have, I think it's 52 different points that we go through, which is pretty helpful when you start out. It's there for free as well. There's a little bit about patient communication, how to sell the treatment, And if you like it, you can always, give us access to whatever aligner tool you're using and let us access that to assess your patient. So if you have a patient where you say, I'd like help with case selection, simply send us an email with the case number and we will guide you to how to let us connect to your doctor platform. So you don't have to upload anything to our platform. We simply tap into your information. And within 24 hours, you will get an email back with an indexation of this patient. Is it easy, moderate, complex, or a referral case? And why? And it doesn't cost you anything. So this is the kind of, free stuff that we have. Of course, we hope that if you like this and you find that, okay, these are dentists and orthodontists only helping me here, well, maybe you would like it to take it to the next step and use our treatment planning service where we help you co-create the treatment plans.
Great. I'll definitely put all that in the show notes. Jesper, thanks so much for geeking out on occlusion and everything in between. Appreciate your time. It's been nice to connect with you again, and looking forward to another time.
Likewise.
Thank you so much.
Well, there we have it, guys. Thank you so much for listening all the way to the end. Thank you to my guest, Dr. Jesper Hatt. I'll put all the links in the show notes. Scroll down below wherever you're watching, listening, so you can check those out. This episode is eligible for CPD or CE credits. We are a PACE-approved education provider. Look, if you're a regular listener to Protrusive podcast, you need to get on the membership. Even if you just listen to one episode a month and you answer CE quiz, that's 12 easy CPD credits or CPD hours you've gained, and you would have learned so much. If you actually start logging into the app and seeing over 400 plus hours of the content we have. Some of our premium clinical videos are just amazing. We have an entire library of webinar replays, and every month we do a new live. And these are really cool clinical walkthroughs. Just last week, we did fiddly and wide class 2 cavity. And we often do them during breakfast time US, lunchtime UK, late night Australia. And the reviews we get for those webinars are just absolutely amazing because they're full walkthroughs. My loop mounted camera's on, we're pausing, we're thinking, okay, which matrix should we choose and what went well and what didn't. And I think that's the highest form of learning. If you like how that sounds, head over to protrusive.co.uk/ultimate. And honestly, the amount of CPD, CE credits you'll get, you won't care about the numbers anymore. It's all about the learning. And also, as well as the learning, we bring the community. It's the nicest and geekiest dentists in the world. I want to thank you guys again for watching to the end. I'll catch you same time, same place next week. Bye for now.